Hello and welcome to a Sagely Health webinar. Today is December 20th, and today we're going to be talking about what you need to know if you were diagnosed with colon cancer. I am joined, as always, by Dr. Jason Sager. Hello, Jason.
Hello, Jeremy. Hello, everyone.
So, we chose colon cancer for a number of reasons. It is the third most common cancer in the United States by incidence, and it also been in the news recently. There had been a celebrity death, and that kind of always kind of brings it up and brings awareness. So we wanted to kind of join into that. And we have had some patients with colon cancer, and there are some unique things you should know about colon cancer, so hence the title of today's. So Jason, in addition to those, anything else you want to add about choosing the topic of colon cancer particularly?
No. I think that's all fine. But there is another major event occurring today, which my understanding is your birthday.
It is.
And so let's just, first of all, wish you a very happy birthday. And then I will spare you the pain of listening to my rendition of Happy Birthday. I'll do that later off the webinar.
The internet thanks you.
Yeah. However, I must ask you, Jeremy, how old are you? And the question is, are you anywhere close to the age of 45 yet?
I am approaching the age of 45. I have one more year. Today is 44.
All right. So next year at this time, do you know what we'll be celebrating?
My 45th birthday, I believe. Yeah.
Yes, and anything else?
Well, I'm going to guess, keeping on the theme, that there's a screening date of some kind.
Yes. So importantly, the colonoscopy for colorectal cancer screening, which is extraordinarily important, has just recently been changed. It used to be that men and women older than 50 would be recommended to have and be paid for by their insurance and everything like that to cover a screening colonoscopy. My understanding is that that age has now changed to 45. And so we'll have the pleasure of guiding you through a screening colonoscopy next year around this time.
Yeah, I don't think we'll be live streaming or anything. But yes.
Yeah. We probably will skip that part as well. I had my own, and highly recommend it. A number of these places are very regimented about how they do it, and so even though it's not the most pleasurable thing in the world, it's also pretty straightforward and really didn't detract from sort of day-to-day normal life, which to me was the major impact.
Yeah, has the introduction of tests like Cologuard changed anything? I mean, do people use that instead? Is that maybe a good thing or a bad thing?
This is a great question. And actually, I find that a lot of people don't know about Cologuard. So let's just jump in because this is really important. We'll back up a step. Cologuard, made by Exact Sciences, what they do is it is a test on the stool, also known as poop. And they give you a bucket, and again, a slightly unpleasant experience in collecting one's own poop in the bucket. That being said, again, they know what they're doing, and there's a way of sealing it very quickly, and you then put it in a pre-labeled box, and you send it back to the company, and then that is analyzed for any kind of signs of cancer. Those include both the common things such as blood in the stool, which if people are seeing blood in the stool and not necessarily the bright red blood that would come from, let's say, a hemorrhoid, but dark, tarry, almost black blood in stool, that's always something of concern and something that you should see your doctor about. They'll test for even microscopic amounts of that blood, but they also look for a lot of the genetic changes in cancer and the genes that are actually shed in the cancer cells that would be in the colon. And so they're looking for that. And if it's positive, it doesn't mean that there's colon cancer. Again, there's lots of reasons a little bit of blood can be in the stool. And I think they have you stop eating red meat for a day or two before, this sort of thing. But they've kind of stacked the deck to be more positive than not. So if it is positive, no concerns, but you do want to get that colonoscopy and discuss it with your doctor right away. If it's negative, you can be fairly rest assured that there's a lower likelihood of colon cancer. Now, it doesn't remove the need to get a colonoscopy, but for those who have difficulty in getting the colonoscopy for any reason, it does add some evidence. And actually, as an example, during COVID and COVID lockdown was when I turned the age to get the colonoscopy, and decided that probably going at risk with the lockdown, I don't even think they were being given at that time. And so I did the Exact Science Cologuard test as a substitute for the time being. And then as soon as the lockdown sort of was lifted, I went and got my regular colonoscopy. So, again, I find that a lot of patients don't know about the Cologuard test, and I do think it's quite an effective tool to add into the detection and screening test sort of scenario.
Yeah, I mean, that is a very unique thing about colorectal cancer, in that this was even possible because there is a substance to test. I mean, we get into it in another webinar, but there are some kind of, the other thing we have is blood, and blood can be looked at, and that's kind of the hope of the future of detecting early. But really, the Cologuard is really an early precursor of looking at a substance as opposed to a scan or a biopsy.
Yeah, and we'll get more into this, but because some of the more recent advancements in immunotherapy haven't found their way into most colon cancer. Again, we'll talk about a subset where if it's MSI-High, and we've talked about that before, then yes, there is an effective immunotherapy for those patients, but it's a small percentage. However, outside of chemotherapy, there's a large number of targeted therapies, and so tumor sequencing with NextGen sequencing is really something that is paramount for colorectal cancer. And again, you see Exact Sciences using it in the Cologuard test. We'll talk about it in a little while, about circulating tumor DNA in the blood. And then specifically can be looked at in the tumor itself. So anyone who has colon cancer and is anything of high risk. So I'd say beyond a stage 1, certainly beyond stage 2, should have a tumor analysis of the for genetic analysis with NextGen sequencing. And those results can then be utilized, if needed, to potentially add therapies or come up with therapies that are uniquely designed to knock out that colon cancer based on its genetic principles, which is an effective method. So, so we'll discuss that more, but that's sort of the main point of the webinar today.
Yeah, and we've got some patient questions that we'll get to, but were a couple points we wanted to kind of go into. So, with colon cancer, if it's caught very early, there's a pretty good survival rate.
Very good.
More than you see in most cancers. But we want to talk a little bit about when it is more advanced and when it is metastatic, because metastatic in colon cancer can mean something very different than metastatic in other cancers, and kind of what your options are. So could you talk a little bit about that? Because I think that's very interesting.
Absolutely. And in general, colon cancer, amongst all of the cancers, grows amongst the most slowest of those. Now, it's not all the time, and we've had cases of colon cancer that have rapidly progressed. However, for most patients, which the colon cancer has been around for quite some time. It may have been missed on a screening. There may not have been a screening done. Eventually progresses. When it does become metastatic, and eventually it will, it tends to go to the liver. And in those situations, though, even there are anywhere from, I believe, 5 to 30% of patients who will fit into a category called oligometastatic disease. This is a very fancy term for saying there's very few tumors outside of the original tumor mass in the colon. And what that means, and unlike every other cancer type, or at least most other cancer types, oligometastatic disease means that you can actually go and do surgery on those tumors in the liver or even in the lungs. And with those surgeries, come out with a much better chance of overall survival than what would be expected, let's say, with almost any other metastatic situation. So, I always hedge my bets when I see a colon cancer patient saying that they have metastatic disease. My next question, because most cancer patients talk to each other, and metastatic disease, it's not going to go well. And again, that may be the case, but for some patients with this oligometastatic, where there are up to 3 nodules or tumors outside of the colon, and that can be 1 in the lung and 2 in the liver, or vice versa, they have the potential of doing better than average. And let me just show you here, because I pulled a reference for this. I'm going to share my screen. And so this is a paper that I pulled. I think it's still coming up. Let me see. Yeah, there we go. From 2013, and there's some more recent. I'll show you another one in a moment. I think from 2020, but they said that basically when you go and remove, and these were patients who had lung nodules, pulmonary. The 5-year survival rate is more than 50%. Now, obviously, we always want to do better than that, and I suspect that since 2013, there have been advancements, and we'll talk about how pre-treating with chemotherapy can help even more. But as of even 2020, there are a lot of other. So surgery is one method, but there's many other methods as well. There's these very specific, what they call stereotactic approaches, local treatments by radiation or by other devices or other energies such as ultrasound, high frequency ultrasound, that can eradicate these tumors. And again, if there's not many of the tumors, there can be an appreciable survival rate for long term from these techniques. And so it's really worth considering in colon cancer specifically how local therapies can help in an approach where there is oligometastatic or fewer than 3 or fewer tumors outside of the colon.
And so these tumors, so a patient would have a scan and they'd be able to say like, okay, we can see the tumor in the lung or the tumor in the liver, and they're kind of clear, differentiated. And it's the fact that they're coming from tumor cells of the colon that when they travel, they kind of set up and they don't spread a lot. They're kind of really identifiable.
That's absolutely correct. Right. The metastatic always happens because the cancer is, it forgets where it belongs, what it's supposed to be doing. That's why it tends to migrate outside of the normal area in which it is found and eventually finds its way into the bloodstream. And the liver is a wonderful filter for blood, and that's where the colon, cancer cells usually travel from the colon to the liver and begin to grow there. Other cancers will metastasize in different ways, but in colon cancer, that's primarily how it gets to the liver and then the lungs.
Gotcha. Okay, so I wanted to shift to something you've referenced already a little bit, but there hasn't been, as we talked about, a ton of innovation in the treatment of colon cancer over the years, and that kind of makes the next-gen sequencing really, really important. And so there are clinical trials out there that are recruiting for colon cancer and considering kind of targeting certain gene mutations. Could you talk a little bit about what we're seeing in colon cancer as far as next-gen sequencing and
Absolutely. And and when we say that there's not been a lot of innovation, there's actually been a lot of innovation in the targeted therapies, and we'll talk about that. But in particular, that immunotherapy approach, the finding that PD-1 and PD-L1, which we've discussed in a separate webinar, sort of came into existence. It had great impact for melanoma, had great impact for lung cancer. Up until now, although scientists will continue to work on it, and physicians too, it hasn't had the impact for most colon cancer patients. There is an exception, and we reviewed that with the New York Times article in rectal cancer, which is fairly closely related to colon cancer. They often are grouped together as colorectal cancer, CRC. So in MSI-High, or otherwise known as microsatellite unstable colon cancer, you will have a proportion of those those patients will be sensitive to immunotherapy. There's another condition that we'll be talking about later called Lynch Syndrome, which is a hereditary basis where these DNA repair mechanisms, the same ones that basically enable, give that weakness to immunotherapy, that's what's causing these. And so those patients, almost all of them, would be responsive to immunotherapy. We'll come to that later. That being said, it's extraordinarily important to get DNA tumor sequencing. And again, right now, we recommend anyone at high risk ask for NextGen sequencing from their physician. There's other varieties of it, and we recommend broad-based panels no matter which way you go. So that can help, and we'll talk about how that will help in a moment, but go ahead.
With colon cancer, what would make you high risk? How would I, as a patient who had a diagnosis of colon cancer or even colorectal, how would I understand that I'm high risk?
Yeah, absolutely. From my perspective, the high risk patients are patients who largely have more advanced stages. There can be other factors, as we talked about, if there's a family relationship where Lynch syndrome may be present. You'll definitely want to get sequencing, not only of the tumor, but of the normal cells as well. But you'll see it in the tumor. And so those are primarily the cases where you'll want to get that tumor sequencing, because it's any time that the tumor has a greater than, let's say, 20% chance of coming back. That's how we set our bar. We'd like our patients to have about an 80% or better chance of complete cure. And if that's not going to happen, we'd like to stack the deck in that direction with things like targeted therapies or even preparation in advance.
So yeah, let's actually jump over to that. So the idea of a cure for colon cancer has traditionally been that you can have a surgery, you can have the tumor removed. There's a lot of pieces that come with that when you have colorectal surgery, and so I'd love to hear you talk a little bit about the surgery, about neoadjuvant treatment as part of that, and just kind of understanding what are the benefits and why should people kind of be hearing that word or bringing that word up if they're not hearing it.
Yeah, absolutely. And, from my perspective, colon cancer, when thinking about colon cancer, surgery is still the best way to get a cure. And so again, that's why early detection is so important, because if you can clip out a polyp while it's still just in the colon, then why not do that? If you can remove it when it's a stage 1 or still sort of localized in the colon. Sometimes you might have to remove a piece of the colon, and we can talk about that as well. And so from my perspective, because surgery is still the very best treatment for colon cancer, that's why early detection is so very important. That being said, a lot of patients don't find out until it is already advanced, stage 3, stage 4 metastatic. And so in those patients, though, there is really two components. The component of where the cancer has spread to and how to control that. And oftentimes, again, that's in a situation where, because it's slow growing, can we find something that slows it down even more, or maybe even holds it in stasis for a very long time, over years? So you get into a situation where it's not so much about trying to be cured from cancer, but living with cancer so that it doesn't kill you. And that is a goal that I believe is obtainable, and that's what we're trying to get patients on innovative therapies like targeted therapies to do better with. Going back, though, the other problem in colon cancer is that when a tumor is sizable, it can actually cause physical problems, obstruction mainly of the colon, and the colon has to work or else you will not do well. And so so from my perspective, even when surgery can be used, doing chemotherapy as what they call neoadjuvant or before surgery is something that can be tremendously helpful, because it'll shrink down the tumor size and allow the surgeon to take out less, do less work and potentially remove less of the colon at the time of removal. And again, when you lose more of your colon, you tend to have more comorbidities, some problems in the future. And not to mention the fact that, some patients will need a colostomy, and the time to get that colostomy reversed, or even if it can be reversed, all matters with the tumor size. So that's where I have patients ask about preoperative chemotherapy, even when they're going to go get surgery.
Yeah, it's probably a good time to kind of plug the idea of creating your own tumor board here. So, could you talk a little bit about what when we say that, what we mean?
Yeah, absolutely. And from my perspective, the best way to achieve the best outcome in colon cancer, or that for that matter, most cancers, is anytime a surgery is potentially involved, make sure when you're going to the initial consult with the surgeon, which is often the one that the hospital will give you, pair it with two others. Meet with a medical oncologist and a radiation oncologist. Can be at the same medical center. You don't have to go crazy about trying to find one outside, but ask when you're just registering is the best time to do it, and set up an appointment not only with the surgeon, but with a medical oncologist and a radiation oncologist. You could also ask the surgeon, if you're in their office, that you'd like to talk to a medical oncologist and a radiation oncologist, can they recommend someone? And by doing that, you really put together a group of doctors to work together. And you mentioned tumor boards, and most centers have tumor boards where multiple doctors get together. And everyone knows that's the best way to get a plan together for attacking cancer, specifically colon cancer in this case. However, most patients don't initially get presented to tumor boards. There's just too many patients and too little time. These things happen monthly or weekly, a handful of people. So again, I encourage patients to basically make their own tumor board by combining these three doctors together and having them talk to each other. And we can help with that too when we're involved.
Yeah, just to review, I'd add one more. So when you're calling the cancer center to make the appointment with the surgeon, ask about seeing a radiation oncologist and a medical oncologist. You can ask your primary care doctor, and you can also ask the surgeon. And so if you don't have luck with one of them, go the other routes.
Yeah.
This is something you are entitled to. Insurance will likely pay for it, and so it's something that it's really should be used.
And if you're asked why do you want to see a medical oncologist, say, well, I want to know if chemotherapy can help either before or after the surgery. The same thing with radiation. So again, I think it's pretty easy to justify, and when patients are proactive about it, they tend to get it done, which is good.
Yeah, absolutely. So I guess we can jump to some questions now, and then feel free to bring up any other topics you wanted to come up from that. But one submission we didn't get a lot of detail, but it was someone asking about the kind of watch and wait versus an upfront surgery, a colostomy, for a young patient based on the pathology, poorly versus moderately, they put.
Yeah.
So
Yeah. And we didn't get a lot of detail, but oftentimes, with the experience that I have, I can kind of figure out what's being asked here. The situation where a young person would be looking at a colostomy with surgical resection of the colon happens mainly in that Lynch syndrome, which is the familial sort of hereditary passing on of those genes that can cause colon cancer. As I said, those patients have treatment avenues that were never ever available before. And in the past, I'd say when I was younger, maybe 20 years ago or so, the standard of care was actually to do surgery. And in teenagers, to remove a lot of their colon, there can be, many different polyps in there, even hundreds, which is, far more than what you or I might have on average. So, but these things have changed over time. And actually, in preparation for today's webinar, I did some deep research on this. And everyone pretty much agrees. There's actually some formal publications that I've pulled out. And if we have time, I'll show them to you. But the summary is that at this point, the best way to in Lynch syndrome is that more frequent monitoring. So these patients will get a colonoscopy every year, and they will get and they will have basically all of the polyps cleaned out on a regular basis. It's felt like doing that is far superior because it leaves them with their entire functional colon, no colostomy to be concerned with, and therefore that's the recommendation. And again, that we don't know whether the question came to us in the U.S. I could understand where if the same technologies are not available, let's say overseas, that perhaps there are places where surgery is still appropriate. But I would say that everyone agreed that at this point the way to go about it is just those annual scopings and looking to make sure that there's no polyps and to clean those out regularly. I'll just say the other advance over the last 20 years is that they realized that aspirin is actually quite effective in these patients at preventing the advancement of colon cancer. And so for the patient who asked this question, they should, if they have Lynch syndrome, they should be sure to be taking aspirin on a daily basis. I know there was a lot of experimentations with fancier meds like some of the NSAIDs, ibuprofen, or even some of the other. And what they found is that aspirin does the same job. And so while you and I might not take aspirin to prevent colon cancer because the risk is low enough, and there's some risks of long-term aspirin like bleeding, but these patients, the risk outweigh the risk of taking the aspirin, and so aspirin is highly recommended in this group of patients.
Interesting. So yeah, it's a little counterintuitive where you might say, yeah, it's actually okay to just watch and wait in this case because the data supports it. Right. There are approaches that are complemented, right, like doing the regular screening.
Right. I kind of react strongly against the word watch and wait because you're not waiting, right? You're doing something. That doing something is monitoring, is active monitoring, and it's monitoring that like you and I wouldn't have. Like we're going to get it when we're 45 and 50, and when needed, but these patients will need it every year, and so that's actually quite active. And and I think suitable in this situation. And and again, there was a question about whether or not if the pathology from the polyps come back as more advanced, like a worse pathology, or less advanced, does that matter? The literature didn't seem to say that mattered. Now, if colon cancer is diagnosed in these patients, then it's treated the same way. So then surgery is involved. And, again, if they can catch it early enough, it could be a very simple surgery. But those are the recommendations today, at least.
Gotcha. Well, great. The next question we had was someone looking for a good colorectal surgeon in the Northern Virginia area. They're unhappy with their current surgeon. They want someone more experienced. Any recommendations on facilities? Even they were even kind of willing to travel up and down the East Coast. Yeah. It seemed. So one, I mean, if we had a recommendation, we could give it. But I think how would one kind of go about understanding a good surgeon versus a not as good surgeon? Yeah. I'm just curious.
Yeah. So the first thing is to make sure that the surgeon who you're seeing is actually a dedicated cancer surgeon, as opposed to a general surgeon. And sometimes these things can be confused. But the best way, from my perspective, to stack the deck is to look for an NCI-accredited cancer center. And this actually applies across the board. So what we don't know from this patient is, are they currently at an NCI-accredited cancer center? If you Google NCI-accredited cancer center, up will come an NCI website with a map and a list of all the centers. And you could easily see which center is nearest you, and that's where I would start. Many patients, you could call the center, ask for a surgical consultation with their cancer surgeon for colon cancer in this case, or any other specific cancer. But the fact is that you could also look online and take a look at who is on their staff. And we do that when we're looking for patients. We also look to see who's running innovative trials in the surgical arena for colon cancer. And that's how we help patients to navigate. But I would say that for this patient, it would be good enough to start with making sure that they're in an NCI accredited cancer center. And if they're not satisfied with what they're hearing, then look at another accredited cancer center. And there's many of them up and down the eastern seaboard. So I'd say that would be the best way to go.
Yeah, and I mean, just to point out logistically, if you are diagnosed and your primary care doctor sends you to a surgeon at a medical center, and if you're not getting the right vibes there, if you don't want to be there, then the option of getting a surgical consultation somewhere else is open to you. Your insurance should, again, cover it. You can call your insurance to make sure. You can ask your primary care doctor to make the referral to an NCI accredited cancer center. You have more advocacy than most people realize. I think that there's a lot of people who kind of go with the flow. They don't want to question the surgeon they meet or the oncologist they meet. And it's okay.
Right.
You can and it's allowed.
Yeah,
I just want
absolutely. And again, there are the questions that I like patients to ask really goes towards the experience of the surgeon in doing the surgery. Do they do this surgery? How many times a month do they do the surgery? Right? And if they don't say, oh gosh, a month, like I do more than 5 or 6 a week, that's what you want to hear, right? If they say, oh yeah, well, a handful a year, that's not usually the surgeon who's going to be best for you. On the other hand, many patients look for someone who can talk to them and really make them feel comfortable. Some of the surgeons are quite outstanding and just don't have that sort of communication skills. But again, if they have the hands and the technical skills and their outcomes are fantastic and they're at accredited cancer centers and they're celebrated, most likely they're going to be able to do a good job for you.
Yeah. And I mean, colon cancer is a little more common. I mean, we've looked at the Whipple surgery that's done as part of pancreatic, and not everyone qualifies. So you might run into a doctor at a local community hospital that has never done it, or it's just not an option in some cases. So with colon cancer, you actually can they're probably going to offer it to you because they do it commonly enough, but you can ask those questions.
Right, absolutely. Sure. And again, with colon cancer, because of that blockage that can occur at diagnosis, sometimes the surgery is urgent or even an emergency, right? And so you may not have the ability to actually get to someone else. That being said, following up with someone else for potentially a second surgery if needed, or just for an evaluation is always a good idea.
Yeah. Excellent. So, so then the person who asked that, feel free to reach out if you want to talk more more specifically about recommendations. We're happy to do so, but we won't spend time today. But the next question we had was about, it's really general, but I thought it was a good one to include, which is my CEA test came back at 27.4 ng per ml. What does this mean?
Yeah.
And I think that's just a common theme with a lot of cancer patients, like helping them kind of understand what they're told are important numbers, and they kind of well, why? Right. What does it mean?
Right.
So what is a CEA test, and what?
Yeah, it's a great question, and it brings about sort of another way to help colon cancer patients that is fairly specific to colon cancer, and that is this circulating tumor marker. What we know is that the CEA is produced by colon cancer cells. Now, unfortunately, it's not only produced by colon cancer cells, and it's also produced by normal cells, sometimes a little bit more when they're stressed. But what we know is that in colon cancer, when you first diagnose it, it's very helpful to get this blood test called the CEA. It's called colon embryo antigen, I think. And so that's what the CEA is for. And if the surgeon gets this test, what they can do is see, is it high? And I looked up before we met today, and the normal range is between 0 and 2.5. And that's that ng per mil, so nanograms per mil. So the 24.7 would be high. Right. Now, what's important about that is that can then be monitored. And so after the surgery, you'll see, does it fall? How far does it fall? Does it fall within normal range? Is it still elevated? And then what happens over time? Oftentimes it will, especially if it's a local tumor and it's entirely removed, it will fall back to normal. Now, over time, it may start to elevate. And really, instead of looking at an absolute value where, it could be 500, it could be 5, it could be 27. What's more important is the trend. Is it increasing steadily over time? And if it is, and it can precede seeing it in an imaging study. So, oftentimes patients will be monitored with CT scans, but the CEA, these blood biomarker tests, can actually see the increase sort of in advance of seeing a solid mass on the tumor on the scan. So it gives a little bit of preparation time to say, well, if this comes back, if we do see it on the scan, what would we do next? And so it also gets more frequently checked, and it's easy to check. So in general, I'd say it's highly recommended. Again, we only have the one number there, so I would encourage the listener to follow up and give us more of the trending over time is what we would look at to try to look at significance.
Yeah, it's funny. I mean, because if that's the first number you've ever read, then yes, that's a high number.
But again,
probably,
if you don't have colon cancer and you get a number like that and you just had pneumonia, yeah, it can be from that, or COVID,
Gotcha.
or like a million other things. So, again, sometimes these things get checked and they're high, and patients panic, like, oh my God, I've got colon cancer because I got an abnormal number and a CEA.
Right.
No, unfortunately, again, no one's using CEA as a screening test for colon cancer.
Right. It's okay. Makes sense. All right. The next question's a really good one. Someone wrote to us and said, I have no evidence of disease, but now have several spots in my liver again. That could be new metastasis. My doctor is not sure and thinks the spots could be remainders from the radiotherapy I had 6 months ago. Should I start chemo again?
Right.
A bunch to unpack there. I mean, obviously there's a history that we can read into that, but yeah, I mean, how should
Well, this is a
person-
great question. And actually, having just finished that segment on CEA, could turn around and quiz you, say hey, what test would you get? And the answer is a CEA, right? Because, but importantly, the important thing is, was it high to begin with? If it wasn't high to begin with, the CEA is not going to be particularly valuable here. If it was, and you get the CEA and it's low, and it still continues to trend low, then the likelihood, maybe the doctor's right, that there is some sort of post-radiation, changes in the scan. However, if the CEA is trending up, then I'd be more concerned and get ready for some more chemotherapy and start discussing that. There is another test, though, which is actually quite specific. And this goes back to our discussion of the tumor DNA. And that tumor DNA, when it is present, especially if it's in the liver, is going to be shedding DNA into the bloodstream. And that DNA can be detected in a test called circulating tumor DNA. That's abbreviated CTDNA, and also has another name which is called Liquid Tumor Biopsy. And so if you Google any of these terms or ask your doctor about it, I would request a CTDNA test to be done. It's done on the blood, just from the arm, so, easy to do. It does, some insurances may or may not cover it. I think in this situation, it sounds quite reasonable that it would be covered. And so from my perspective, it's very specific. There's no other reason to have mutations floating around the body that are linked to the cancer. And so again, especially if you had the initial cancer tumor sequenced, you can use this test. If you see the same mutations floating in the blood, you can be pretty sure that that's the cancer. And yeah, starting therapy sooner rather than later, if you are sure it's the cancer, is going to be helpful. I'll just end with saying that you could also have the interventional radiologist or a surgeon can do a biopsy of the liver mass. Sometimes, though, in this case, it sounds like they're probably too small to sort of be assuredly kind of go, even with CT guidance, imaging guidance that can be used. Oftentimes, these things can be very hard to hit. So my preference would actually be to do the ctDNA first. If they grew any larger or got to the point where they could be biopsied, then I think their doctor would recommend a biopsy, and I would go with that. And then I wouldn't treat with the chemotherapy unless one of those things were positive. But if they were, then certainly discussing and getting access to chemotherapy or other innovative therapies could be very helpful.
Makes sense. I mean, it also comes down to a little bit of the tolerability of the chemotherapy for the patient, and if they want to be proactive about it. But
Yeah.
interesting. I always thought of the circulating tumor test as kind of like an option if you couldn't have a biopsy. Like we've had patients where the biopsy material wasn't sufficient or was lost or something where and they don't want to go through another biopsy, so they're like, well, you can do the blood test. But it's interesting to think of it as more of a monitoring tool as well.
Absolutely, absolutely. I was just in a discussion about a patient this morning, and said, yeah, if there's any question about it, it would be straightforward to do this test. It's easy to do. It's a little bit expensive sometimes, but if you find it's positive, it's very specific. And we've been talking a lot. I wanted to show you guys, show everyone a little bit more about this nature of the genetic changes that are seen in colon cancer, because from my perspective, and this is something that is an advantage of the system that we've set up, we can do a search where we see that here 152 therapies exist solely to target the gene. So I filtered down the vast number of therapies, and this is for actively enrolling trials in the United States. So I think if I relieve that, it would be something like 400 or 500 therapies. But you can see very clearly, I mean, the list of genes that are involved in colon cancer that are being targeted is fairly robust. And some of I can see, I don't know if you guys can see the smaller numbers here, but as we go through this, genes like BRAF are very common and commonly targeted. EGFR, another family that's commonly targeted. The RAS genes, HRAS, KRAS, and later on, because this is in alphabetical order, NRAS are very commonly targeted. But again, you can see some of the things like neurofibromatosis 1 gene. Yes, there's a trial for that. PI3 kinase. And then this one down here is one of the newer ones, UGT1A1. I've started to see pop up here and there. So again, from my perspective, getting tumor sequencing, especially if the tumor has come back or is at risk or later stage of coming back, that can really be helpful. And I hope that by showing this, people can see just how many options potentially exist just by looking at the tumor.
Well, that goes into our last question actually pretty well. So this is someone who's talking about their father who has been diagnosed with stage 3 rectal cancer. So that puts us in that kind of higher risk bucket we talked about. They want to avoid surgery, and they don't, because they don't want a bag for life. They don't want a colostomy bag, and so they're asking, are there any drugs, local treatments like radiation, chemotherapy? Are there trials or immunotherapies there? And they happen to mention they're on the East Coast. So, I mean, what you're showing are these are trials that are trying to target gene mutations. So I can tell from our discussion they should be next-gen sequencing kind of as soon as possible if they haven't to find out.
Absolutely. So just summarizing from everything we've talked about today, I think this is the perfect case. Yes, next-gen sequencing on the tumor, for sure. In addition to that, neoadjuvant chemotherapy to pre-shrink that tumor so that the surgery can be as minimal as possible. There are actually trials for patients that are combining these various agents together in a way to eventually to try to avoid surgery. And we've seen specifically in that 10% of patients who have MSI-High, either colon cancer or rectal cancer, that this study came specifically from rectal cancer, was published in the New York Times, that all of those patients responded, and many of them didn't need surgery at all. And so, from my perspective, following this path leads to the greatest potential of being able to minimize the surgery, potentially avoid the surgery, or even if you do need a colostomy, again, it would be a smaller one that could be potentially reversed at a later time.
Yeah, I mean, the New York Times story, just to kind of give a timeline to it, that was published this past summer. And they waited about 2 years before they made the announcement because they were monitoring if the cancer was going to return in these patients. And there were 18 patients who were treated with immunotherapy because they were MSI-High, a particular gene mutation, or not a gene mutation, but something that comes out of when you do the NextGen Sequencing report. So you kind of go backwards, and like this is something they started testing maybe 5-6 years ago. They really started. And so when you look at it, like that's why we're talking about the NextGen Sequencing, because we look what's coming down with trials, what they're trying, what's working, and it's the more targeted you can get, the better. So I just can't kind of underline that enough, that if there's anything I get for my birthday this year, I'd like it to be everyone to get NextGen Sequencing.
Sounds like a great wish. I will join you. It's not my birthday, but I will join you in that wish. And yeah, and again, when we talk to our patients, I'd say close to 100% of them wind up with NextGen sequencing for their tumor. We're dealing generally with high-risk patients, but we can help everyone, and the benefits from getting that are immense.
Yeah, absolutely. So I think we'll wrap up there. I would like to just remind everyone that we have a feature on our website that if you'd like to ask us any question about cancer, whether it's your diagnosis, whether your treatment, your options, as specific or general as you want,
or a loved one,
we're here. Yeah, absolutely. So at sagewayhealth.com, you can find that. And obviously and if you want to talk privately, we're available for that as well. So with that, I think we'll wrap it up. I think this was great information. And we'll get this posted online so people can take it in.